Tony, thank you very much. Ash, thank you very much for the kind invitation to come down and talk tonight, or this afternoon. My charge was to focus on a critique of screening, specifically screening in the United States. And I think there is a distinct difference from how we use PSA testing compared to many of the rest of the world. One second, that's not my first slide. Well, let me continue from here. Screening in the United States basically began with this manuscript published by Tom Stamey in 1987 and took hold further when Bill Catalonia published this in 1991. I know this because this is the years that I moved to Connecticut in 1987, and it was PSA testing was just arriving in the state of Connecticut, and we were arguing whether we should biopsy someone with a PSA of 8 or 9 or 10 until 1991 when Bill Catalonia said we had to biopsy everyone with a PSA over 4. In fact, it was Bill Catalonia who suggested that we should be doing PSA testing on an annual basis, and the rationale was we would find more cancers. And we all know this had a dramatic impact on the incidence of the disease. No other cancer shows a dramatic change in the curves due to one single innovation, PSA testing. We have virtually doubled the number of men diagnosed with prostate cancer in the United States since the introduction of this test. We know from what Fritz Schroeder has just shown us that PSA testing works. This is a positive study. I think most of us look at the PLCO trial and realize it's probably underpowered. Even more important was the recent publication of the Swedish trial, which took us out from 9 years to 14 years, suggesting that, exactly as Fritz just suggested, that if we wait long enough, we will in fact have a more dramatic change. And Jim Hanley's paper published last year also suggests that further benefits from screening are likely to take place when we go from 15 to 20 years. What are the key aspects of these trials, and how do they potentially differ from how we use screening in this country? Key point, in the ERSBC trial, most countries were screening every 4 years. With this, we saw a relative reduction of about 20% in prostate cancer mortality, and the figures we all know, 1,410 men need to screen and to treat 48 prostate cancers to prevent 1 prostate cancer death. In Sweden, the screening interval was every 2 years, twice as often. With that, they saw a 56% relative reduction in prostate cancer mortality. 293 men need to be screened, treating 12 men to prevent 1 prostate cancer death. It's the screening interval I want to focus on, because we don't use either of those intervals. We use an annual interval in the United States. How does screening frequency impact disease incidence? I think many of you have heard me talk before that I believe there's a large universe of cancers, those that progress rapidly, those that regress slowly. I think, Ash, you talked about there are really 2 kinds of cancers, those who kill you. Those in this slide are the green men, and the orange men, those who have cancers that are indolent and for some reason do not progress rapidly enough to pose a problem during your lifetime. When you introduce a PSA test, you dramatically increase the pool of men that can be diagnosed. We've seen that already. Our incidence curves document this. What's more subtle, however, is the more aggressive cancers, the cancers we need to find, have a shorter window of opportunity, and the orange cancers, the men we shouldn't be finding, have actually more chances of being found on repeated PSA testing. So again, this annual interval potentially has an impact. Dr. Rubell in the audience published a very interesting paper looking at this question. She compared the 10-year cumulative incidence from the Rotterdam data, which is the ERSBC trial, screening every 4 years, with the Gothenburg data, which is screening every 2 years. And she showed, in fact, you can find increased number of cancers. But when you look at the interval cancers, the number of cancers found in between, the number is relatively few, and more importantly, the number of important cancers, the ones you surely have to find, are many fewer. And these are the curves that she published. And they show us that, yes, increasing the frequency of testing finds more cancers, but doesn't necessarily find the more important cancers, the ones that we need to cure. So how is PSA practiced in the United States? Well, this was recently published by Drazer. What was the other message we heard from Dr. D'Amico and from Dr. Schroeder? Screening interval, 55 to 70. I've flagged those by the big blue arrows. This is where we have validated PSA testing. But how do we practice PSA screening in the United States? The vast majority of men being screened are over age 70. In fact, 70 to about 85 is the window gets the most predominant screening in the United States. What is life expectancy by age? Well, when you start getting around age 80, you're falling below that 10-year window, which we've already shown PSA testing does not, in fact, impact survival. And what do we know about the progression of the tumors in this group? Well, the whole interest, my research interest started back in 1987 when I began seeing many men on our operative schedule who were being treated for radical prostatectomies and were having complications. I was trying to ask that question, what was the natural history of this disease? And I think many of you are familiar with the slides which we showed that men with low-grade cancers progress slowly, men with high-grade cancers progress much more frequently. But when we look back at our curves from the original publication, these were all based on men in the pre-PSA era. Trying to validate this in the post-PSA era, we went to the SEER system to look at more contemporary survival curves for men who have PSA testing. Why? PSA testing advances the date of diagnosis by as much as 5 to 10 years, and therefore your 10-year outcomes are going to be very different. So these are survival curves based on men identified in the current PSA era. As you can see with T1C disease, even among those men age over 80, the death rate from prostate cancer is relatively modest. That's not so true for the high-grade tumors. Again, the bad cancers, the cancers that kill you, the Gleason 8, 9, and 10s. These are the ones we need to find. However, they are the less common ones when we screen. Another issue that's caught my attention is the whole issue of comorbidity and how we measure that. We recently published this just earlier this year in the Journal of Clinical Oncology, the impact of comorbidity. Men with relatively few comorbidities, those are the top curves, show in fact a relatively low death rate from any cause over 10 years. But the minute you have 2 comorbidities or more, the likelihood of surviving 10 years is fairly modest with either low-grade or high-grade disease, and therefore the likelihood of benefiting from screening is much less. This is for stage T2 disease, which you can see is not dramatically different from stage T1C disease. So let's focus on that bulk of patients, or a good number of the men who are being tested and screened in the United States, those men aged 75 or above. What is happening here? Well, we recently did a study, and we've submitted this for publication, involved looking at the SEER system. We focused on the men 70 years and older, and went back and asked how many PSA tests had they had in the previous 5 years. You can do that because Medicare starts at 65. So we had a group of men we found who had no screens. We had those who had 1 PSA test, all the way up to 4 PSA tests, and therefore we could calculate how many of these older patients had annual testing or less frequent testing. And we again clearly showed that whether you're 70 or 80, the more PSA tests you have, the more likely you are to be found with prostate cancer, just based on the frequency of PSA testing. And that would be a good thing if we in fact found the bad cancers and left the men with the good cancers alone. But in fact, the majority of men we find we treat. Fully 82% of the men treated in over 75, whether they had low-risk disease or high-risk disease, despite their comorbidity, they all received treatment. What treatments did they receive? Mostly brachytherapy and radiation therapy. Some received androgen deprivation therapy. Relatively few were managed conservatively. If you extrapolate these outcomes based on what we're seeing versus a no screening, you can see we have an enormous amount of treatment being expended at age 75, 80, and 85. And the question is, this has all not been validated. Are we in fact achieving much when we do this? These are the questions that in fact the public health physicians are beginning to look at and ask seriously. Who does in fact benefit from treatment? We have more limited data, but we all are aware of the Swedish trials that clearly documented and advanced based on the radical prostatectomy. And we look at it when we go 12 years out. There is in fact some difference, but it's not as dramatic as we'd like to think. When we look at the JNCI data from 2008, we notice in fact the benefit for men over age 65 is not there in a subset analysis. The men benefiting from treatment are the younger men. And we look at another study that was just published this March in the Journal of Urology. This is the outcomes of virtually all the major US centers in terms of radical prostatectomy. This is a case series data. But unfortunately, the very men we need to find, the Gleason 8 tumors, the ones that kill you, when they get radical prostatectomy, more than half do not benefit from this disease, or excuse me, benefit from this treatment, as shown in these graphs. What about radiation therapy? Unfortunately, the data is less robust. We do have Anders Widmark's study, which shows definitely a benefit from radiation therapy plus hormonal therapy, but again, out at 10 years, it's relatively modest. So what are the challenges in my mind for 2011 for PSA testing as practiced in the US? PSA testing appears to lower prostate cancer mortality in a modest number of men who are less than age 70. However, annual PSA testing as practiced in the US identifies an excessive number of men over age 70 with this disease. And many of these older men receive treatments that carry minimal benefit and expose them to significant morbidity. The challenges in my mind are to refine PSA testing algorithms so that a positive test is more likely to identify that man who has clinically significant disease. Ideally, we want to refine PSA testing guidelines to decrease the number of older men who receive this test, either by stopping PSA testing completely or by increasing the interval between the tests. So again, we find the clinically significant disease, not those as incidental findings. And finally, we are not doing a good job at matching the appropriate interventions to the threat posed by this tumor. Thank you very much.